Yes, there was always a question on how many treatments should receive a patient, or when we should have a signal to switch the patient to systemic therapies, right? And this has been in the field for a while. So when you check the trials, the phase 3 trials with assessing chemoembolization, at the end, the median number of sessions is 2.3, 2.5, 2.8, 3. So it's between 2 and 3. It's not that you are thinking about 5 treatments, 6 treatments, either 2 or 3 treatments. This is the median number of treatments in the trials, and this is the reality. So beyond that, generally you are not providing benefit to the patients. If you don't get the benefit in 2 or 3 treatments, this is over. The more difficult question is when to switch to systemic therapy. And this in the period of time where only sorafenib was in the field. Then certainly the physicians were pushing a lot chemoembolization, and when the patient was at truly advanced stage, then they switched to sorafenib, and there was a need to start sorafenib early on, but this was not happening. Now I think this will be a natural thing because you have 6 potential treatments that are effective, so therefore physicians are more comfortable to switch to systemic therapy because you have frontline limbo, sorafenib, then you're moving to second line rego, then you always may have, I don't know, checkpoint inhibitors. So the physician will be more comfortable to offer different options to the patients, and then the switch that generally should happen when there is no response at all or progression of the disease will happen early on. I envision that.
So I think there are different triggers for systemic therapies. First of all, it depends on the tumor burden. If you have big tumors, bulky disease, vascular infiltration, extrahepatic disease, they would all trigger systemic therapies right away. In contrast, if you have smaller tumors, and if these are candidates which are in BCLC stage B, we usually would start with local therapies such as TACE. And then the question is, how long can we do and how often can we repeat TACE, for example? And I think this is a very important point, because in the past, and what we are doing general in oncology, is that we would accept stable disease as an outcome which is sufficient. But this is different for local therapies such as TACE in HCC, because with all these therapies we are applying, we can also damage the liver and we can deteriorate liver function. So we now have some data that patients that respond to TACE have a very good outcome. In contrast, if they have only stable disease and if they do not have deep responses after, for example, 2 TACE treatments, I think this should be a trigger to consider systemic therapies, and these patients should not be treated repeatedly with TACE or other local therapies such as Y90.
Yeah, metastatic disease, which is it's a extrahepatic spread, means local regional therapy is not effective. So as soon as the metastatic disease was diagnosed, we introduced systemic therapy.